The next set of medications that are used preoperatively for these people to try to stabilize them is to give them calcium channel blockers. The downside of calcium channel blockers when you start adding everything else to it is that they begin inhibiting contractility, and some of these medications that we give are inhibitors of contractility as well, so sometimes they can add the effects and cause significant depression. The diuretics themselves are always contraindicated prior to surgery because they're such preload reducers, so we don't let them, we stop them the day before surgery, or the day of surgery. We're asked not to take them. The other thing you got to watch out for is most diuretics cause hypokalemia, so you want to make sure that that's not taking place. ACE inhibitors are very controversial. You should use them right before surgery. Most of us have actually gone away from giving ACE inhibitors anymore to patients that are going in the operating room simply because we're getting such severe hypotension in the operating room. Okay? The only thing that holds your blood pressure in the operating room is three things. Okay? You have your sympathetic drive. Okay? You have the ACE component, okay, which is angiotensin, that also maintains your blood pressure. And the last one that's really, really, really weak, okay, is what? What do you got left? Vasopressin, okay, which is really weak most of the time. Okay, so it's really not something that would be a factor under most circumstances. Okay, so when you give somebody fentanyl, what you're doing is you're suppressing the sympathetic activation. Okay, so that brings that side down. And then you add somebody with an ACE inhibitor. Now you're taking out the angiotensin component out, and then what you're left with is vasopressin to maintain your blood pressure. So there's very little left. And then you get severe hypotension that doesn't seem to respond to anything that you're doing. Okay, you give ephedrine all day long and it just doesn't seem to work because of all these potential preoperative medications that are given to these people. Antihypertensive medications, you got to be careful about not going crazy about them. You got to make sure that the blood pressure is adequately controlled prior to surgery, but not enough that makes them hypotensive on induction. Digitalis is potentially dangerous medication in the sense that it has very low therapeutic index for toxicity. The first thing I ask anybody who's on Dig is, do you see any yellow halo at all? And if they say yes, then they're toxic, and that person should be really put back until this problem gets taken care of. Management of patients with ischemic heart disease, you've got to determine the extent of disease. So when you ask a cardiologist, don't ask them to clear the patient for surgery. Ask them specific questions. One of the things I ask them is, what is the extent of the disease? Okay? What vessels are affected? What stents are put in, or what kind of procedures have been done to make this guy better? Okay? What is his medical management, or is his medical management optimized? And I'm very specific about that. If they say that all those things are taken care of and they give all the details on it, then I basically have reduced my risk as much as I can, and off we go to the operating room. Okay? You're never going to make the risk zero. Okay? You can take somebody who's 20 years old, put them to sleep, and they're dead at the end of the procedure. Okay? You can have somebody who gets a malignant hyperthermia, gets a reaction to the antibiotic that you're administering. They could have cholinesterase deficiency, and you extubate them when they're weak. There's a lot of problems you can encounter in anesthesia. Okay, so you don't ever take anything for granted. There's always risk in what we do. Okay. What they've done recently is they've changed some of the cardiac risk index by looking at what kind of procedures are being done. They found that actually high-risk procedures really carry a lot of risk with it. Of course it does. Anytime you go in the abdomen, anytime you're doing a major vascular repair, anytime you're going into the chest, you're putting the risk up. Okay? If you have patients with ischemic heart disease, yes, the risk goes up. Patients that have congestive heart failure also increases the risk. Now, on the other hand, if you've had a patient with a stroke, does it really increase the risk? And the answer is variable depending on who you read. Okay? Most people will tell you that, of course, cerebral vascular disease, if it's induced by heart thrombus formation, then you really should check the heart before you take the patient back to the operating room. The other thing that also increases the risk is insulin-dependent diabetes. Okay? And then patients with renal insufficiency with serum creatinine levels of greater than 2 milligrams per deciliter, which means that you got over 50% renal insufficiency at that point. Yes, sir?
Is there risk
These are all risks for post-operative complications, okay, or perioperative complications. So you could have an MI, you could have, ischemia afterwards. It's a very variable risk model. The risk modification tells you basically that the patient can be either elective or emergent, okay? If you have an elective case, what you're trying to do at that point is you want to reduce the risk as much as possible. So if you have stable symptoms, you stratify risk together, which we'll show you here in a minute. If you have unstable angina, on the other hand, and it's an elective, you really should put that person back until you have a cardiologist see the patient and see if they can be medically optimized at that point. So you really should at that point stop the case. If you have no choice because the patient needs emergency or urgent surgery, then you're going to have to medically optimize the patient as fast as you can and then take them back to the operating room. Okay? And by that means you should put them in the ICU, and maybe the ICU doctor can help you try to get the patient optimized prior to surgery. Okay? That's the ideal. Major clinical risk factors when you're looking at this is unstable coronary artery disease, decompensated heart failure, any kind of significant arrhythmias. Severe valvular diseases also carries a lot of risk. May require a delay of elective surgery and cardiology evaluation, and it requires intensive preoperative management as necessary if surgery is urgent or emergent, which means that they have to go to the ICU. Okay? This is the risk factors that you see. When you do vascular surgery, look how much higher the risk is. Okay? The risk is much higher with a 12% major cardiac complications post-operatively. In comparison to orthopedic procedures or peripheral procedures, you're down almost to baseline. Baseline is around 3%. Okay? So this is around 4% the worst case scenario. Okay? We're looking at 4 major risk factors put together. Okay? When you're still looking at thoracic or abdominal, they're double the risk of peripheral procedures. They're at 8% usually. Okay? So don't just think that the person has low risk. Just because they're having orthopedic procedure, it doesn't eliminate it completely. It just means that they're a little bit lower, about half the risk that under other major procedures are being done. If you have elective surgery for a stable clinical condition, you have high intermediate risk surgery, you want to see if the patient has been revascularized or prior revascularized. If he has no prior revascularization, you stratify risk further, which I'll show you in the next picture. The prior revascularization, you look at for the patient's had a prior CABG. Okay? If the patient's been under 5 years and with no medical changes, then there's no need to do a stress and procedure to do the surgery. Okay? We used to do stress tests for these people, and we found that was really not a good yield of findings. So as long as the patient's not developing any symptoms within less than 5 years, don't do anything. If the patient seems to be stable. Okay? On the other hand, if the patient has had a percutaneous placement, okay, you can either have a placement of 2 kinds of stents. You have the bare metal stents or the drug-eluting stents. Okay? This is a little bit changed in the last few months because what we're finding out that even people that have drug-eluting stents really require long-term antiplatelet therapy, which is Plavix. Okay? What we're finding out is that what we thought was that drug-eluting stents were going to eliminate the need for Plavix, and that's not been the case. Okay? What bare metal stents basically do is, let's just give you a history first. The first kind of stent that was put in was bare metal stents. And these are actual little stents that are made out of a specialized metal that when it actually is expanded, it holds the atheroma away from the coronary middle area, so it basically opens the vessel back open. Okay? The danger of the actual metal is that when exposed to the blood vessels, to the blood components, it shears them, breaks them apart, and it causes heavy endothelialization to occur too fast, and as a consequence, the area will narrow back down again. Okay? So what they did to prevent that from happening is they gave these people Plavix, which basically prevents the platelet adhesions, and then the endothelium will basically cover that area more gradually, and up to about anywhere between 6 to 18 weeks. Okay? If you do that, then you can stop they thought that you could stop the Plavix. Okay, so the bare metal stents, they were stopping the Plavix fairly early. Now the drug-eluting stents were supposedly that you're putting these stents in, but they had a drug in it that would prevent the endothelium from reforming. Okay? So it would take up to a year before the endothelium will actually cover the stent. And those people were going to be put on Plavix for a long period of time because the stent was still exposed to the blood. and it would cause clotting to occur. So those people are going to be put on long-term Plavix therapy. They still found that even after the endothelial wall reforms over the stent, they're still having to give Plavix because the patients still have an increased risk of actually developing a blood clot in that area. So Plavix is still going to pretty much be with us for a very long period of time. It's really good for the Plavix company because now they're going to have these drugs being chronic therapy of stents. Okay? The benefit to you is that you don't have to have open heart surgery. The downside for us is guess who we take care of? We don't take care of 70-year-olds anymore for open heart surgery. Now we're doing 80-year-olds. So we've offset the disease process for about 10 years, and now we're putting high-risk patients in the operating room for now open heart surgery. So it's not that they've gotten less sick, now they've gotten actually more sick. The good thing is that now at least a lot of people don't come to the operating room like they used to. That's a good thing. Okay. The thing is it worth the cost? That's a big question. It's very expensive to say the least. As to why is it so expensive, I don't really understand the whole logistics of that portion of it. When you have high-risk surgery, which means emergency vascular major surgery over your aorta is basically disintegrating, or other major vascular surgery has to be done, or any kind of peripheral vascular surgery, your cardiac risk are going to be greater than 5%, okay, no matter what. Prolonged surgical procedures also associated with large fluid losses also are considered high-risk surgeries. The intermediate risk surgeries are the carotids, okay, head and neck surgery, intraperitoneal or intrathoracic surgery, orthopedic surgery, and prostate, and the cardiac risk factors are less than 10%. Low risk are the ones that are like endoscopic procedures. We don't do a full cardiac evaluation on somebody who's having an upper endoscopy or a colonoscopy. It's considered a low-risk procedure. Doesn't mean that you won't get into complications, but the risk is much lower. Eye surgery also tends to be a low-risk surgery. In the old days, we used to do, I think, about $4,000 worth of preoperative labs on all these people and for eye surgery, and none of it was really doing us any good. So now the recommendation for eye surgery is do nothing. Just talk to the patient, patient's stable, off you go. Okay? Superficial surgery, which is skin surgery, is what the dermatologists do, as well as we do in the operating room as well. That's pretty straightforward. Breast surgery also has very low risk as well. Okay? 1% risk of perioperative cardiac complications with that. Moderate clinical risk factors are stable angina, previous MI, compensated or previous heart failure, insulin-dependent diabetes, and renal insufficiency. These are well-validated markers for enhanced risk of perioperative cardiac complications. So these are actually studied, and these are actually shown that they have an increased risk. So this is one of the test questions I'm going to ask you. What are considered moderate clinical risk factors? Now, what you do with elective surgery, the patient's high to intermediate risk factors and no prior revascularization. If the patient has stable coronary artery disease or good exercise tolerance, then no need to do any stress tests and proceed. If you're unable to assess the coronary artery disease or decrease exercise tolerance, you need to do some testing at that point. Most commonly, that's a non-invasive testing, such as echo or some other procedure. If it's significantly positive, if it's not, then you can proceed to surgery. If it is positive, then you need to go to the gold standard, which is cardiac cath. From jumping from here to cardiac cath is really not a smart idea. You should go with the non-invasives first. What's the risk of putting somebody in a cath for having a complication? It's 5%. It's not a low-risk procedure. Okay? So don't do that. Make sure that the person is just getting non-invasively tested first. Minor clinical risk factors is hypertension that's fairly well controlled. Left bundle branch block or nonspecific ST segment changes. We see that all the time. Some people try to make a bigger deal out of nonspecific ST segments. They basically are a minor risk factor. You shouldn't be jumping up and down with that. Okay? Patients with a history of stroke, they used to be said that they were high risk factors or not. They tend to be on the lower risk factors. Okay? These have not been proven to independently increase perioperative cardiac risk. So we used to say 10 years ago this would be considered part of the high risk profile. They're not. Okay? They're actually on the low risk side. Management after risk stratification is that sometimes these patients may require revascularization by open heart surgery, or they require revascularization by percutaneous coronary intervention, which is the stents. When you do have a patient that's had stents, please don't just say, how many stents do you have, and that's it. No. You got to ask them, okay, how many stents do you have? Okay, I have 3. Okay. What kind of stents do you have? Oh, I've got both kind. I've got the stent, the bare metal stent, and I've got the drug-eluting stents. Okay. What medications have you been on? Plavix. Have you had any more recurrent symptoms? No. Okay. So at that point, I know exactly what's going on with him. I know he's been treated with Plavix, and I also know that he's at low risk at that point because he's not getting any recurring symptoms. If, on the other hand, he tells me, when I ask him, are you having any symptoms? Do you get any chest pain, any shortness of breath? When you walk around and move and exercise, you get any kind of symptoms of pain on your chest or any kind of dizziness or anything like that. If he says yes to any of those, then that person is at high risk again because they may have actually now re-occluded or partially occluded one of those stents. And that patient should be sent back to the cardiologist to be evaluated again. Okay? Most people will give you symptoms, okay, when they get advancement of disease again. Okay, and they'll be able to tell you that. Okay? So you got to determine the date, the kind of stent, and any stent-related complications. We do tell you one thing, that any patient that had a recent stent, that's the other thing too. When a cardiologist puts in a stent, they used to tell us, oh, don't worry about it, they're fine. No, you don't do somebody who just had a stent put in. Okay? And you ask yourself why. Why isn't it not safe to put somebody who's just had a stent put in? Why can't you just take him back to the operating room? And the answer is simple. One of the things that we do when we cut somebody is what happens to coagulation. It increases. You become hypercoagulable. Okay? And before you do this procedure, you've had to stop the Plavix. So now you're in a really big disadvantage. The person has a stent that will increase the risk of thrombosis, and now you've made them into a hypercoagulable state. And so now you have a perfect storm of having an MI post-op. So what we do is we tell that person at least for 4 to 6 weeks before surgery to make sure that the Plavix kicked in and some of the endothelium walls formed. Okay? So 6 weeks for bare metal stents. That's how long it takes for the endothelium to recover. And if it's a drug-eluting stent, you actually got to wait a year. So if you have a cardiologist and he tells you, well, I'm going to put a stent in, and you better ask him, says, well, we need to do the surgery. We want to do it in the next 6 weeks. What are you going to put in? And if he tells you, well, I'm going to put a drug-eluting stent, says you can't. You got to do a bare metal stent. Okay? Because the recommendations are you have to wait a year to do for drug-eluting stents for do surgery. Okay? Review the timing of the proposed surgery. Discontinue modifying antiplatelet therapy through the use of multidisciplinary team of cardiologists, surgeons, and anesthesiologists. I love how people write this kind of stuff down, and the probability of doing that as a multidisciplinary team is, when the heck do I see the cardiologist ever? Okay? He's so busy, and I'm so busy that most people don't have time to. If I pick up the phone and talk to him for about maybe 30 seconds, I'm lucky. Okay? So for me to sit down with him is just unrealistic. I know people write this stuff down, but those people are obviously not in clinical practice. Okay? The optimal thing to do, of course, is to stop the platelets appropriately, which is usually Plavix has to be stopped how many days before surgery? How many days? 6 to 7 days. Yep. If you want to do regional anesthesia. Okay? If you're trying to do just regular general anesthesia, it's up to the surgeon to decide at that point. If he wants to do it right away, and he knows it's a minor procedure, I don't mind, whatever. It's not going to cause a problem. I'd rather have the Plavix still on board anyways, because it decreases my risk post-operatively for this guy having an MI. The biggest risk if you're doing anything major abdominal or major thoracic, then you're going to have a lot of bleeding. Then you don't want to be in that situation. But for like peripheral procedures, inguinal hernia or something like that, they can bovie to it very quickly. Shouldn't be a problem. Okay?
How long do you have to wait without symptoms so that they're at low risk after stent placement?
You really can't say that. Most people after, if you're doing a bare metal stent, you're looking at about 6 weeks before the endothelium will completely reline it. So when you stop the antiplatelet therapy, they should be okay. Okay? Yeah. Okay. But when you've got the other form, which is a drug-eluting stent, because endothelium takes such a long time to revascularize, that could take up to a year. then stopping the Plavix is very dangerous in that situation. Pharmacological nitrates helpful for active ischemia. Prophylaxis really have no help at all, okay? And it's actually potentially dangerous in the operating room. Beta blockers have also been found to be very helpful in decreasing the risk of postoperative MI. And what you want to do is you're trying to titrate the heart rate to around 60. And the biggest problem with beta blockers is that everybody decides to stop them right before surgery, and then the person rebounds and gets hypertensive and tachycardic in the recovery room because beta blockers have a half-life of around 8 hours. So they can break down pretty quick. Okay, look at the clinical risk factors. Things that are major risk factors are vascular surgery. Okay, these are the clinical low-risk surgery has pretty low risk overall. Best treatment, no, there's not one magical drug, really isn't. Okay, there's not one perfect treatment. What I try to teach you guys is that these people may require multiple drugs to treat their problem. Okay, and the reason that is because everybody has slightly different forms of atherosclerotic coronary disease. Some people will have more small vessel disease. Some people remold their heart more. Some people dilate their heart early. So it depends on their different situations. And that's why these multiple drugs are available for you to make sure that you get as best control as you can. Surgery, of course, we just talked about this, showing you about the inflammatory and the neuroendocrine response. Really, what we actually try to do is we try to block each one of these steps so we don't have a problem. Okay, you can see the inflammatory response is actually shut down by statins. Antiplatelets or anticoagulants are broken down to stop the hypercoagulable state. We can hypoxia, of course, giving oxygen, transfuse in case you have decreased hematocrit. Nitroglycerin is used for vasoconstriction post-op, so you don't get that, okay, and hopefully prevent a decreased oxygen delivery. And decreasing blood pressure, you want to prevent hypotension. Everybody says that, so it's not as easy as people say it is, though. Anesthesia and ischemic heart disease, what's your goal? Prevent myocardial ischemia by optimizing your coronary perfusion pressure. Monitor for ischemia and treat if it's observed. Okay? Intraoperative events that increase your risk, okay, are decreased oxygen delivery, things like decreased coronary blood flow, tachycardia, diastolic hypotension. Hypocapnia is also not a good thing. So hyperventilating somebody is not a wise thing because it causes coronary vasoconstriction. You can also get coronary artery spasms, which lead to decreased oxygen content due to anemia or arterial hypoxemia. And you actually may cause a shift of oxygen dissociating curve to the left in certain situations. Increased oxygen requirements occur due to sympathetic nervous system activation, which is very common in the operating room. Tachycardia, hypertension, increasing myocardial contractility increases workload, increasing afterload, and increasing preload all lead to increased oxygen requirements. This basically shows you the risk associated with developing ischemia in somebody with elevations of heart rate. You can see the highest risk factor is here. If the patient's heart rate is over 80, they actually had some troponin ischemic changes on EKG with troponin changes of around 24%. Okay, the actual EKG changes were as high as 55% with the higher heart rates. And you can see how patients under less than 70 heart rate, you get troponin changes of a very mild increase of 6.7. Okay. So they're basically showing you that it's really, you need to keep the heart rate down quite a bit. Induction for patients that are having ischemic heart disease, there's different kinds of techniques. It depends really what you're trying to achieve. Okay? If you're going for open heart surgery, we give a stable induction with high-dose narcotic, benzodiazepines, followed by Pavulon or pancuronium. The reason pancuronium is added is because it has an atropine component to it and accelerates heart rate. And you say, well, Dr. Nolan, isn't accelerating the heart rates bad? The answer is yes. But when we're giving high-dose fentanyl, 40, 50 cc's of it, we're actually going to cause a severe bradycardia. And the two offset each other, and the heart rate basically remains stable. Okay, so giving Pavulon is a good idea. If you give vecuronium or rocuronium, your heart rate will be in the 40s, and you may have a very significant hypotension at that point. Okay. The other thing that's also helpful for induction of medications is most of us avoid ketamine. Ketamine is a drug on induction that causes decrease myocardial contractility directly. It will cause sympathetic discharge, which then increases heart rate, increases the SVR, but that's an indirect effect. Okay? But the actual direct effect of ketamine on the heart is it decreases myocardial contractility. Okay? Most of the time you don't see it because of the increase in systemic vascular tone and increasing heart rate, okay, which is another thing you don't want to do when somebody has ischemic heart disease. You don't want to push their heart rate up. So ketamine we don't tend to use. The drugs that do seem to work adequately, but it tend to be all preload reducers, but if you're in failure, it means be appropriate, are patients like dialpental, pentothal, and propofol are appropriate preload reducers. The other drug that we use that's more stable in patients that are kind of unstable is etomidate. Okay? Etomidate really doesn't cause too much of a preload reduction and doesn't really cause too much of an afterload reduction as well. So it's one of the most cardiac stable medications that you give somebody that's under for any kind of procedure. So if you have somebody with a low EF of like 15 to 20%, that's the drug we pull out. It's etomidate. Okay? No. No. Heart failure is, if you increase heart rate in that situation, may push them into increasing myocardial oxygen consumption. So we don't usually give ketamine to somebody who's in failure. Some people will actually give it to somebody who's in mild failure, give ketamine combined with Diprovan at low dose concentrations, and it maintains kind of a stable blood pressure. I think if you're going to do that, why don't you just go with etomidate and forget about the craziness. The reason I don't like ketamine is because it also has a dissociative anesthetic, and it can take prolonged awakening from somebody. And the downside to it is also it can cause a lot of confusion in these people, okay? Which is, you don't know if it's from the low perfusion state or rather just from the medication. Some people have actually used it very effectively. I've seen it done. So I'm just telling you my bias. You'll see some people will mix it with propofol and combine it together. Propofol has zero analgesic properties, but when you combine it with ketamine, ketamine has analgesic properties. It's a dissociative anesthetic, so you don't have any pain that's being sent to your brain, okay? Or it stops basically at the thalamus. It basically breaks you away from the cortex of your brain, okay? So in that sense, it's kind of helpful to maintain stable blood pressures in that situation, okay? But the only thing I'm worried about is that sometimes it increases heart rate and increases oxygen consumption, and that may put you at a higher risk, especially at high doses of it, okay? Intubation response, they tell you about this in clinical a lot. LTAs do seem to work. Okay? The problem with LTAs is that it takes a few seconds for it to work. You're supposed to do a double intubation to do a proper LTA. The first thing you do is you do with a laryngoscopy is look, and then you take the laryngeal-tracheal analgesic, which is basically 4% lidocaine. You put it into the trachea and you spray it, and then you come out and you ventilate again for about 30 seconds, and then you reapproach the airway again. So you're doing a double intubation. That's the downside to it. The benefit of it is when you do put the tube on the second time, you're not going to have any effect. Okay? The downside to it is you're doing 2 intubations. And when you put somebody, if you don't think laryngoscopy hurts, put a blade in your mouth and you tell me if you can hold it in your mouth. It's not something you want to do while you're awake. Okay? So it's uncomfortable. Okay? And especially when somebody's trying to push open your mouth. The LTA doesn't take care of that. Okay? So you're still going to get that sympathetic discharge. So that's really not something that you're going to reverse the effects of completely. Lidocaine helps but does not prevent it IV-wise. Esmolol has been found to be very effective. Okay? Esmolol, when you titrate it to a heart rate of 55 or 60, when you intubate somebody, they almost have no response at all to their sympathetic discharge. Okay? Fentanyl has also been found to be very helpful, but what they're talking about in those kind of situations is that they're giving 100 mics to 50 mics per kilo. That means 70 cc's of fentanyl if you're 70 kilos. Okay? Or 140 cc's if you're going to 100. So are you going to do that for most cases? The answer is no. Okay? So when you're giving 50 mics up front or 100 mics, you're really doing nothing. And you may think that. Okay? But the original studies were not done that way. The original studies were done on heart patients, and they were found that they they get no sympathetic discharge absolutely at all when you give high doses of fentanyl or morphine. Okay, but it's not something you can do regularly. If you give 500 mics to a 70-year-old patient, they're not going to wake up. Okay, they're going to stay nice and comfortable, and they're not going to wake up afterwards. So we almost never do that. You almost see me do on 75-year-olds. I won't give fentanyl at all. Okay, most of the time I would rather deal with hypertension than deal with hypotension. The most common problem is on induction is that people cardiovascularly try to collapse on you. So adding fentanyl is really not such a wise idea on over 70. If you have a 40-year-old, on the other hand, fentanyl up front is a good idea because they're going to get a lot more sympathetic discharge, and they're going to zoom upwards on blood pressure on you. You had a question? They would also work, but you get the same complications as you do with any form of narcotic. You will induce apnea in somebody. Okay, the good thing about most of those medications is that they wear off very quickly. Fentanyl, the way it actually stops termination of action is that it redistributes. Okay, and remifentanil really breaks down very quickly because it's broken down by what? Cholinesterases in the blood. Okay, so that's why it stops so quickly. Okay. The downside to remifentanil, of course, is that if you give it too quickly, somebody will get chest rigidity syndrome. Okay, I've even seen that with fentanyl as low as 50 mics, and that can be a real panic, to say the least. You can't ventilate these people at all, and you have to give them muscle relaxant to reverse that effect. Okay, I've had people look at me and they're awake and they couldn't breathe with 50 mics of fentanyl. Okay, not that they didn't want to breathe, they just couldn't. Their chest wall was so rigid. And you can't ventilate them either. So you have to actually put them to sleep and give them succinylcholine quickly to reverse it. And of course, by that point, your sats are 90%, and you hope you made the right decision because usually at that point, you're going to drop to 60% saturation unless you start ventilating pretty quick. Okay. Maintenance, nitrous oxide works just fine. We use it in open heart surgery all the time. The only thing is you don't want to use it once you get closer to cardiopulmonary bypass because of bubble formation. So we usually go to high 100% FiO2 at that point. Usually about 20 minutes before we go into cardiopulmonary bypass, we shut off all the nitrous, and that by that point it's zeroed out of the system, so it doesn't go into any air bubbles. What basically it does is it tends to have less an effect on the cardiac than anything else. All the volatile anesthetics are cardiac depressants to a certain degree. Nitrous oxide doesn't have that ability to do as much harm. So if you have a patient who is hypotensive and you're told to shut off the nitrous, that's really not the thing to do. Leave the nitrous gone. It's a great amnestic. Cut back your isoflurane first. That has much more cardiac depressant effects than nitrous oxide. Now, the reason the blood pressure comes up when you shut off the nitrous oxide, it's not because of the cardiac depressant effects. It's what you've done is you've taken the MAC and halved it. And the patient's actually waking up. That's why the pressure's coming up. Not the effects and the depression on the heart. You've actually now got the sympathetics kicking in, and you're getting the blood pressure rising because of it. Okay? Volatile anesthetics, halothane, isoflurane, SIBO, and desferrine are all depressants. Okay? They all depress the cardiac motility. You have what's called a muscle to blood coefficient. That will tell you how much depression you have musculature compared to that specific agent. Halothane has a higher muscle to blood partition coefficient. So halothane has the most cardiac depression effects. Okay. The next one after that is actually SIBO. Okay. The next one after that is ISO, and the least one of that is desferrine. Okay. Now, what also that tells you is that skeletal muscle is also affected by that value. So if you have a choice between which drug should you use for somebody for abdominal surgery, and you want their muscle to relax in the abdomen, isoflurane and SIBO are very effective. Desferrine is not going to help you. Okay, so if you have abdominal surgery, I don't really recommend desferrine most of the time because simply you can't get the muscles to relax unless you plan to use high doses of neuromuscular blockers the whole case. I've demonstrated to you guys that the volatile anesthetics will cause areflexia to a certain degree. in the clinical area as well. You can also use nitrous narcotic technique that was used many, many years ago. Again, the biggest problem is that once we go on to cardiopulmonary bypass, we shut off the nitrous oxide because of the air bubble formation. It enhances air bubbles. The downside of that is that persons wake up when you rewarm the patient. So what we're doing now, as you'll see that our protocol here is, in most places, is that you start a Diprivan drip, usually 25 to 50 mics per kilo per minute, right as the time that on bypass you're starting to rewarm. That way the medication keeps the person amnestic. Most people that emerge from anesthesia and they hear things are doing cardiopulmonary bypass procedures. Okay? And I've actually had somebody who that happened to, and I just went back and talked to them. And they said, "Don't worry about it, Doc. I didn't hurt. I knew you guys were there, and you guys put me to sleep very quickly. It didn't hurt at all." And at the time, I knew he told me exactly when he woke up. Because we were having a conversation, not that I was having the conversation, the surgeon was having the conversation, and he was able to quote back what the surgeon was saying. Okay? But he said it didn't hurt him, and he enjoyed the conversation about the golf. He says he's got to try the links. So, pretty tough guy. Okay? Most people would be freaking out and need a psychological evaluation and everything else, and this guy was like, "Yeah, no big deal. I survived it." The surgeon was having a good time. He was laughing it up while I was doing his heart surgery, so, But something you want to avoid. It's not something that's really too good. Okay, we learned real quick after that. Make sure that we had the guy with 30 milligrams of Versed, and he still remembered. I've had 1 milligram of Versed, and I wouldn't wake up for 4.5 hours. So I can't imagine giving somebody 30 milligrams of Versed and still have any kind of memory. But the guy was a heavy drinker too. Okay, so if your P450 mechanism is driven up, you can break this stuff down pretty quickly. Okay, you give 30 milligrams to a normal human being, he's not going to remember anything for the next 24 hours. Neuromuscular blockers can be safe. Some of them are not. Remember, Pavulon increases heart rate. Pancuronium is about the only one that increases heart rate. The rest of them can. Some of them, the benzoyl-isoquinolones can vasodilate you due to release of histamine. So be careful with those medications. The more cardiac stable medications are the aminosteroidals, which is Pavulon's part of them. The only thing that's different about Pavulon compared to the other aminosteroidals is it has atropine as part of its structure, and that's why it increases heart rate. When you combine it with narcotics, so it kind of equilibrates and gives you a perfect heart rate. Monitoring, which one's the best? By far the best monitor for ischemia is TEE, by far. It overestimates most of the time that you're having ischemia. Okay, but it's by far, it's one of the things that I use when I'm in trouble. When I can't figure out something, I don't bother doing anything else. I just put a TEE probe and look. And it tells me a lot more about what's going on. Okay, I had a patient the other day that we started the case, and the blood pressure was 62, and saturation was 82%. On 100% non-rebreather, and basically your skin from here down was bluish tinged. Okay? So we put her to sleep, got her through the induction, very stable, still had a blood pressure of 62, so we didn't go up or down. We gave her scopolamine. Scopolamine basically is a dissociative. Okay, it's an anticholinergic, so it basically sedates you and puts you to sleep. And keeps you asleep for about 8 to 12 hours. And then at that point, we put in a PA catheter. In fact, we put a central line in and put an A line in. We had the A line before induction. And the CVP didn't really tell us very much. It was it was very low. It was like 8. But they'd already given her 6 units of blood in the ICU. We put a TEE probe in right away, showed that the heart was completely empty. And so we basically refilled her. We put another 7 units of blood in. And with that, her blood pressure still stayed at 72 on levofed and epinephrine. Okay. What we ended up finding when we got into the belly was that the bowel was completely ischemic and dead. So, it was nothing you could do anyways. But when you get to those kind of end-stage processes and you're looking at everything, and then what we found out also is that she had aspirated when she had gone down to radiology, which everybody forgot to tell us. Because we couldn't figure out why the sats were 82%. We couldn't get them out of it. It ended up being a shunt. Shunt is due to the lung collapsing due to an inflammatory process. And when we did a bronch on the person, we saw that there was actually gastrografin still in her lungs. We suctioned that out, reopened the lung, got the saturation back up to 80%, back to 90%. That's the best we had the whole case. On 100% FiO2. So that's bad news, to say the least. Ischemia pretty swiftly ensued in the next half an hour, 45 minutes, and the patient died in the ICU. Okay? But monitoring-wise, TE by far is more sensitive. EKG, PA catheter is the next most sensitive in the sense that it's able to sense mitral valve regurgitation. So you get the PA waveform, you get an enlarged V wave. Okay? You get the double hump on your PA waveform. And the last one, which could be as much as 30 minutes after the actual transesophageal changes, is the EKG changes, where you get SC segment elevation or SC segment depression. SC segment depression is ischemia. SC segment elevation is infarct. And that's not what you don't want to see. Okay? But so you see EKG changes occur very late. It's 30 minutes into it. So that should tell you something. TEE by far is a better thing to do. Myths. The biggest myth that you'll hear in clinical is they'll tell you not to reverse somebody. That's the biggest mistake you could possibly do. Okay? Everybody should get reversed. If you give somebody a neuromuscular blocking agent, everybody deserves to get reversed. Okay? And the reason being is if you don't reverse them and the person's weak afterwards, that's going to increase your cardiac workload a lot more than the actual medications that we give to increase heart rate. Okay? You have a combination of the anticholinesterase inhibitor and you have the medication which is an anticholinergic together. Okay. What I recommend you do is at least give 0.4 of the anticholinergic, okay, of usually glycopyrrolate, and then give 1 cc less of it in comparison to the actual neostigmine. Okay, so if you give, let's say, a woman 4 milligrams, I would give 3 cc's or 0.6 milligrams of glycopyrrolate. Okay. If I were giving it to a man, you get 5 milligrams of neostigmine and 0.8 of glycopyrolate. That 1 cc less will make an increase in heart rate around 15%. Okay? If you do a 1-to-1, you'll have a 30% increase in heart rate almost every time. That's why there's such a bad press for reversal agents. But if you just give it with 1 cc less, it's perfectly okay. There's no point in reversing somebody without giving it as a bolus. To titrate it in is ridiculous. You'll hear that said over and over again. I'm tired of saying it, but I'm going to say it again. Okay? When you give reversal, you give it as a bolus. The medication works as a maximal effect by knocking out the anticholinesterase. Okay? The inhibitor, it binds to the anticholinesterase and inhibits its action. And that drives the acetylcholine levels higher, which then pushes off the competitive drug, okay, and pushes it away, and then you can start working again. If you give a low dose of it and you only block only part of the anticholinesterase, okay, then what you're left with is still breakdown of acetylcholine, and you never get that giant ramp up of acetylcholine, which then pushes the competitive drug away. So it makes no sense to do that. Also, what doesn't make sense pharmacokinetically, when you administer like say a neostigmine, how long does it take to peak? 8 minutes. 8 minutes. So why would you give it as a titrated effect? If you're giving only 2 and then you find the person's still weak and then you give them 2, you're going to have to wait another 8 minutes for that person to be fully reversed. Makes no sense. Give it all. Just reduce your Robenol just a little bit, okay, and you'll be fine. You have to give at least 0.4. The reason you have to give 0.4 is because if you don't, you can get just partial block of the anticholinesterase activity, okay, and you can actually get severe bradycardias, which also what worries me tremendously is that people are titrating it, and what are you doing when you're titrating it? You're giving a low concentration of Robenol, and you may actually cause a bradycardia. So I don't think that's very wise to do. Okay? The other thing that you're not allowed to do, okay, when you get to clinical is you have to mix these drugs. It's the only drug I ever ask you to mix together. Okay? Otherwise, I don't want you mixing drugs. I don't want you mixing lidocaine with that propofol. I don't want you doing all that stuff. I want you to only mix neostigmine and robenal together. You never give one drug separated and then put it in separate, because this is what will happen. If you give neostigmine to somebody without an anticholinergic first, you will kill the patient. They don't respond well. They don't come back. Okay? So to give it as a separate drug, and then you give the robenal first, and then you follow it by neostigmine, that's great if you're a smart guy and you know exactly what you're doing. But if you screw it up and you give the neostigmine first, the patient's dead. Okay? Don't do that. Mix them together. It's the only time I tell you to do that, and then give it as a bolus. Now, you'll be told differently in clinical. Just remember what I just told you, all the pharmacokinetics reasons for why you shouldn't do it that way, what the drug action, how it works. Okay? And you'll be told to do a certain way. Whatever. Just follow what you're being told. But then when you get into your private practice, you decide which way is better. Go read about it. Don't just listen to what people tell you to do. Okay? Weakness has risk. Some people actually will tell you not to reverse people. If you have anybody in recovery room that dies from apnea, you will might as well write out the check if you didn't reverse. Every expert will bury you, okay, because you didn't reverse the patient. Plus, you just killed somebody because you didn't reverse them. The most common problem that people have post-op is that they develop increasing weakness and they develop hypercarbia. And hypercarbia is hard to figure out because what it does is it causes it causes CO2 narcosis. The patient goes to sleep and the patient looks just fine. And all of a sudden now they cardiac arrest because their CO2 is in 140s, they have a seizure, and then they stop breathing completely. So don't do yourself the ill will of not reversing somebody. Treatment, identify the source, pharmacological management, remember MONA, okay? Beta blockers may be needed. Hypotension, treat with vasoconstrictor drugs and fluids. Give inotropes. Intra-aortic balloon pump should be a very early consideration. And then you may also consider possible cardiac catheterization or open heart surgery.